G'day, I'm Jared Powell, physiotherapist. I have a keen interest in shoulder pain, currently researching this as part of my PhD at Bond University, and I also run a niche shoulder clinic helping people with all things shoulder pain. And you're listening to the Physical Performance Show.
And the winner is...
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome back, or welcome to the Physical Performance Show, brought to you by the Gold Coast Marathon and Pogo Physio. I'm Brad Beer, sports physiotherapist by trade and training, and founder of Pogo Physio. As per the intro, the aim of this show is to educate and inspire you towards the pursuit of your own physical best performance. And we do this through interviews featuring some of the world's top physical performers and also some of the world's preeminent experts in their chosen fields. Each week, we'll bring you a range of episodes, including interest editions, coaches' corners, featured performers, and also expert editions. And on today's episode 167, I bring you a conversation that I recently had with physiotherapist and PhD candidate Jared Powell. And this conversation focuses entirely on the diagnosis, management, and rehabilitation of shoulder pain and injury. And this is a huge area and long overdue to focus on for the Physical Performance Show. By way of bio, Jared is a Gold Coast-based physiotherapist who is currently completing his PhD in shoulder pain at Bond University, where he's also a visiting lecturer and tutor. Shoulder pain is an enormous burden on society, with half of the population experiencing shoulder pain in any given calendar year. It's the third most common complaint that general practitioners field from their patients. And for those that have suffered from shoulder pain, you know what an impact it can have on your daily function and your overall well-being. Specifically on this episode, Jared and I dive deep into rotator cuff pathology and frozen shoulder. Jared shares some evidence-based guidelines on the management of these common conditions. He explores the role of surgery for shoulder pain and also the role of injectables in the treatment and management of shoulder conditions. So I encourage you, even if you aren't currently experiencing shoulder pain, to tune on in with a pen or your iPhone handy and take notes. Let's jump in with Jared Powell on this expert edition on all things shoulder pain and rehabilitation. Jared Powell, fellow physiotherapist, I've been looking forward to speaking with you for quite a while, knowing your knowledge base and your interest and skill set around all things shoulder rehabilitation and management. It's certainly something that on the expert edition side of things, we have been wanting to put out for some time. So thanks for joining us on the Physical Performance Show.
No worries, Brad. Great to be here.
Jared, just a little bit about yourself first. What does a life look like in a typical week in your life look like?
Brad, so I'm a physiotherapist, obviously, as you just alluded to. I work sort of solely in private practice in regards to my clinical work. And I've been doing that really since I graduated 7 or 8 years ago. So to sort of couple that, I do a little bit of work at Bond University as well, where I have an involvement with sort of lecturing the shoulder to budding physiotherapy students, and also do a bit of clinical facilitating work there as well, and in some tutorial capacity. So I'm also doing my PhD at Bond Uni as well, looking at frozen shoulder, which is a mountain of a job. I'll say at the start, there's a lot to get through, which I'm sure we're going to talk about today. And then, so sort of within my private practice work, I run a bit of a niche shoulder clinic as well. So as I'm starting to get more known for treating shoulders, I seem to be treating a lot of shoulders, which seems to be sort of taking up 70 to 80% of my caseload. So So I work 3 or 4 days a week in private practice, sort of I have a day to myself of doing personal things in the middle of the week, which is basically just spent working and reading journal articles. And then I operate this knee shoulder clinic on a Saturday, which is good fun.
Why the shoulder? What interests you about the shoulder? Was this just an accidental discovery that, this area, or is it something that particularly interests you?
Yeah, it's a good question. So I stumbled in it a little bit. There was I'm sure you've heard of Jeremy Lewis. There was an article I read by his sort of 7 or 8 years ago. I think it was published in 2011 called Subacromial Impingement Syndrome, Is It a Clinical Illusion? And I read that and it really resonated with me because it kind of validated a lot of the doubts that I was having about the treatment of shoulder pain and the sort of the challenges with subacromial impingement, as it were. And so I started to read more, and especially more of his work. So Jeremy Lewis is actually one of my PhD supervisors, so I'll probably make reference to him quite a lot. And I read a lot of his work, and it sort of made a lot of sense, and I found that we were still probably stuck treating shoulder pain in a very biomedical way, very mechanical way. And I was seeing a lot of research come out in regards to low back pain, and we'd very much, well, on appearance anyway, we'd move forward using the biopsychosocial model, and I wondered why we were stuck not doing that in the shoulder. So I started looking a little bit more and sort of got back into the academic world, as it were, a year or so ago, and started to do my PhD, and here we are. So it was more just a passing interest at first, and now it's turned into a full-blown career, essentially.
Isn't that fantastic? And, you act your way into clarity, I think, with careers. You just take that next step of interest and, things just keep opening up. And certainly frozen shoulder is something I'm looking forward to unraveling a little with you today. In terms of, Jared, the things that we really want to discover, share around today, it's certainly rotator cuff injuries or pathology and the frozen shoulder condition. But before we go there, broadly speaking, if someone's got a sore shoulder, I like to always keep things really simple as I can in practice. And I really like Adam Meakin's sports physiotherapist. His very basic way of looking at a shoulder, where he divides them into weak and painful, stiff and painful, and unstable. What sort of framework do you use if someone walks in to see you, sore shoulder? Do you use a framework or break things into groups, or how do you approach it?
Yeah, it's a great question. So very, very similar to Adam Meakins, who again is another mentor of mine. So weak and painful, stiff and painful, unstable is good. I change it a fraction. So I go to, is it pain related to the soft tissue of the shoulder? So that can include anything from muscle to tendon to AC joint to even labral pathology. And then I do, is it pain related to a stiff shoulder, which is very similar to what we just talked about a second ago, which includes frozen shoulder, glenohumeral joint, osteoarthritis, and a couple of other more sinister pathologies. And then the unstable shoulder, which I think speaks for itself. And then one more category is the pain being referred into the shoulder. And I think that's a very important one, especially because we know the relationship between the cervical spine and the shoulder as well. So it's very important, I think, to rule out conditions that can refer into the shoulder. Otherwise, you're not going to get too far with your intervention if it's aimed at the shoulder.
And I think that's a really good little segue before we dig into these topics that, if someone's getting shoulder pain, they really do need to be well assessed by someone that knows what they're doing to, as you say, rule out things that aren't even shoulder related, such as referred pain from the neck. So that's great. Well, with that little prelude, rotator cuff pathology. First of all, what is the rotator cuff?
So the rotator cuff, so the holy grail of the shoulder pain, it's I think 70 to 80% of all shoulder pain presentations will involve the rotator cuff. So it's huge, and we know that shoulder pain is just so prevalent. It's the third most common musculoskeletal presentation to any primary care practitioner. So if 70 to 80% of all shoulder pain presentations are related to the cuff, then we have to know about it. So it's essentially four muscles: supraspinatus, infraspinatus, teres minor, and subscapularis. You don't really need to know too much about those. Three of them externally rotate the shoulder and one of them internally rotate the shoulder. So the subscapularis is the odd one out there that internally rotates. But they're not just active during rotation of the shoulder. And this is another really, really key point. And the work of Karen Jin has really led us forward in that. So if you were to flex your arm forward, then that is actually directly activating the posterior cuff. So that's your supraspinatus, infraspinatus, and teres minor. If you were to extend your arm, which is essentially putting your arm behind your back or behind you, then that's preferentially activating the subscapularis, which is the anterior rotator cuff. So this has direct implications into how we rehabilitate the rotator cuff. So if someone's coming in and they've got an issue with their posterior cuff, so they've got a supraspinatus tendinopathy or a partial thickness tear or whatever, then you don't just have to do rotation exercises to load up that muscle group. You can simply do a flexion exercise. So be it a front raise or something similar, that can actually have really good results in loading up the posterior cuff as well. So the rotator cuff, although its name suggests it rotates, which it does, it also is active during flexion and extension movements as well.
So we get it. It sits at the shoulder there. It's involved with every activity really of the shoulder at the shoulder joint. But in terms of conditions, what if someone's suffering from a rotator cuff condition, what are the conditions that they can tend to be experiencing?
Yeah, so look, there's probably an array of conditions. So with the rotator cuff, if we're going to look at pathoanatomy, right, or pathology related to the anatomy of our shoulder, especially the rotator cuff, then you start off looking at something called a tendinopathy. And I know you've had Peter Malliaris on recently, who specialises in tendons, and so listen back to his episode if you want to go more on tendinopathies. So that's probably the number one condition that I see, a tendinopathy, and then we're getting into the realm of a tear. So the first tear that you see is typically a partial thickness tear, and that's usually a tear that only involves maybe up to 50% or a little bit more of the tendon, so it hasn't fully gone through the tendon. And then that can progress to a full thickness tear where the entire depth of the tendon, for example, the supraspinatus tendon, has been torn. And so you've got your tendinopathy, your partial thickness tear, and then your full thickness tear. So
tendinopathy, partial thickness, and full thickness tear. And certainly the word tear, we both know as clinicians that, often... a general practitioner, a GP, a doctor may have sent off for some imaging, and the patient or the client or the individual walks in with an ultrasound report with the word tear on there, and often there's a bit of work for us to do to educate around whether that's of any validity to their case or not, and what it actually means. So can you just speak from your knowledge there, Jared, around tears? Are they bad or are they not, and how do people determine their situation?
Great question. So I see this every single day in the clinic, and in fact, this morning I probably saw 8 people with shoulder pain already, and 7 of them were in relation to a full thickness tear of their rotator cuff. So in regards to the sort of severity or the influence of that, it's not that great a deal. So if we look at just the straight up statistics of a full thickness tear, or sustaining a full thickness tear of the rotator cuff, it increases every decade of our life. So in your 30s and your 40s, it's quite uncommon to have a full thickness tear. As you get into your 50s, your 60s, your 70s, and your 80s, they can really start to affect 1 in 2 people. So up to 50% of people can have a full thickness tear. And here's the real catch. You're twice as likely to have an asymptomatic full thickness tear, so a full thickness tear without pain, than having a full thickness tear with pain. So twice as likely to have a tear without pain than having a tear with pain. So that's really the first thing that I quote to somebody who comes into the room with a full thickness tear. They've got an ultrasound scans and it says full thickness tear. What do? Do I need surgery? So I sort of take a step back, we go through the statistics of it all, and we look very, very clearly that you can exist very, very well with a full thickness tear of your rotator cuff if we manage it well. And we'll get into that a little bit later. But but it doesn't mean it's surgery as soon as you see that on scan.
Yeah, I think that's such a key point. And I'm looking at a laminate that I use in the rooms here from the NHS, where it's a paper-sided, and the percentage of the pain-free population with the finding of rotator cuff tears, they've listed as 22%, and tendinopathy of the rotator cuff 25 to 39%. So I think that's a really key message. So Jared, we're talking all things rotator cuff tendon injuries here at the moment. What are the symptoms that someone may be experiencing if they've got a rotator cuff injury, if you like, or condition?
So I'll just quickly before we go into that, I'll backtrack a little bit. So when we're talking about a full thickness rotator cuff tear, I think the mechanism of injury is really important. So and I go into this a little bit more in my shoulder course. But if somebody sustains a full thickness tear in a traumatic fashion, so they fall over, they didn't have shoulder pain before, and then they have shoulder pain now, they go and get an investigation done, and it reveals a full thickness tear that's bigger than 1 centimetre or 10 mil, then that person should be referred for an orthopaedic review. Okay, so that's really, really important, because those people don't do very well conservatively. So if you sustain a full thickness rotator cuff tear in a traumatic fashion, so there's been a clear cause and effect, then I would advise getting an orthopaedic review on that as soon as possible. If it was an atraumatic or more of a degenerative rotator cuff tear where you can't pinpoint a specific incident, then the statistics show that they can be managed very well conservatively. So I thought I'd just clear that up, Brad.
No, that's a great point. It certainly matches with my observations in my 13 years of being a physio, is that those non-traumatic types do tend to go on and do well. And so that's, and obviously the traumatic types can still occur in the younger or more mature populations. So that's
right.
Yeah, no, that's great. Thank you for sharing that. So what signs, symptoms might people be experiencing?
So we'll start with symptoms. So typically it's pain in the anterolateral, so sort of the front to the side part of the shoulder, right around, I guess, the bony prominence of the shoulder there. And that can radiate a little bit laterally and even a little bit sort of down the arm, down up near the deltoid region as well, or what we call the deltoid tuberosity. So that's the common location of symptoms. Very, very unlikely to get pain that radiates down beyond the elbow. In fact, if it is radiating beyond the elbow, I would definitely sort of consider other pathologies which may be at play there. Other signs you can get some pain in the evening when lying on the affected side. It's not usually painful if you're lying on the unaffected side. So if you're lying on the sore side, maybe that can cause a bit of compression or irritation, which can cause some pain. It's typically an exertional pain pattern, so you lift your arm and it hurts, or you contract the tissues of your shoulder and it hurts. You don't really have a lot of pain at rest, so it's usually movement-based and positional-based. Usually the worst position is a sort of a 90-degree movement out to the side, what we call a painful arc maneuver, and that seems to provoke a lot of stress through the rotator cuff. I don't think it's causing impingement at that point. I think it's more just putting extra load through the rotator cuff, which is already sensitized. So there's some signs and symptoms there. You may also get some pain as well with resisted external or internal rotation, both in neutral or up at 90 degrees or 45 degrees as well.
No, fantastic. And then in terms of people's activities, what might they be doing to produce it? I've certainly observed, in a younger generation, a younger population, that, there's often that, customary spike or increase in loading of some sort of activity, be it swimming more or whatever it may be. But then I also see clinically, mature folk who haven't really changed anything. It's just crept up on them a bit more insidiously. Could you add anything to the patterns of activities that you've observed?
Yeah, so spot on, really. So younger generation, there typically has to be some sort of increase in loading or some sort of unaccustomed activity that they've done. The classic is off-season, where they have 8 weeks off and then get back into heavy training, be it swimming or cricket or baseball or tennis or something like that. This heavy increase in load, the tendons can't handle it, and you get this tendinopathic presentation or a reactive tendinopathy as if you look at the Cook and Purdom model. But then if you get into the older people, yeah, sometimes it can just come on, but generally there is some external factor which takes them over the edge. So it really just could have been a day spent in the garden, which for them may just be a typical activity, but it can be enough to just overload the capacity of that tendon complex to handle. And also let's not rule out factors that aren't physical either. So if you've been dealing with a lot of emotional stress lately, if there's work troubles, if there's financial stress, if there's anything that can sort of result in a stress response inside your body where you get this vicious cycle of cortisol release, and you get this sympathetic nervous system activity going on as well, and you get some amygdala and hippocampus activity going on, that can sensitize us a little bit to pain as well. So external factors definitely, but also don't rule out internal factors that can sensitize us to pain as well.
And I think that's such, and I know this is an area of real interest for yourself, Jared, but as you said, we've so often over the decades approached a shoulder so biomedically or mechanically looking at how it works and forgetting the input of some of these intrinsic factors, like you just touched on, stress, etc. So that's great. And so, Jared, I think if we jump across to a term that you just used, which is impingement, to maybe then come back to managing this rotator cuff world of pathology. So impingement, you mentioned that a lot of the times these rotator cuff conditions aren't technically presenting as impingement. I know when I graduated, that was the buzzword. I think most shoulder conditions did get labelled as being impingement. And certainly in more recent times, that terminology has fortunately faded away, or is fading away. But can you speak to this concept of impingement and why it's now being vigorously challenged?
Yeah, certainly, Brad. So it's a real area of interest to mine, because not only is impingement being challenged, I think actually using the term impingement is a real nocebic term and can actually harm people. So we'll get into the literature surrounding why it's being challenged. And really ever since Jeremy Lewis started publishing literature in regards to subacromial pain syndrome or subacromial impingement or rotator cuff tendinopathy, whatever you want to call it, he has been questioning the validity of the actual pathoetiological process of impingement. So whether, and I guess we should describe what the model is. So the impingement model suggests that whenever you lift your arm into a certain position, there is some form of friction or contact of a bony prominence of your shoulder blade or your scapula, called the acromion, against the underlying tendons of the rotator cuff or the bursa. So the theory was, and this is a theory that was presented in 1972 by Charles Neer, so nearly 50 years ago, in a research study that was no better than what we sort of see a blog as being today. So he suggested that 95% of all issues related to the rotator cuff were caused by this friction of the rotator cuff against the acromion. And so that model perpetuated for nearly 50 odd years until it started to get challenged in the literature. And it culminated in a study that was released only last year in 2018, which was called Can Shoulder Arthroscopy Work? And it was a bit of a controversial study in that they compared people who went in and had a true and actual subacromial decompression surgery, which they go in and they cut a bit of bone to try and decompress your shoulder. They compared that to a placebo surgery where essentially the patient was opened up, a few arthroscopes went inside and they had a look around and then they closed them up. So they didn't actually change any of the impinging structures. They were left in situ and unchanged. And then they followed this up over a year, I believe, and they compared it to a control group who did nothing. And both the surgical and the placebo group got better at the exact same rate at every single time point for the next 1 year. So it really suggested, like in a perfect way, that the impinging structures may not be the issue, given the people who had fake surgery got better at the exact same rate despite having these impinging structures in situ. So that came out last year, and it was backed up again by another study called the FIMPACT study, which was done over in Scandinavia. And the one I just mentioned before was done in the UK and published in The Lancet, so the most prestigious medical journal you can imagine. And this other one, which I'm about to talk about, the FIMPACT, was published in the British Medical Journal. So very, very elite journals here. And this FIMPACT study found the exact same thing. There was no difference, and they followed it up for 2 years. So even the year after, there was no difference in placebo surgery and real surgery for subacromial impingement, as it were. And in this study, the FIMPACT study, also included an exercise group as well. And the exercise group got better, not as good as the surgical groups, but only like maybe 0.5 difference on a VAS scale after 2 years. So it wasn't statistically as good, but clinically the exercise group got better at pretty much the same rate as the surgical groups as well. So these two studies came out within the past 12 months, and it's really called into question the diagnosis of subacromial impingement. And so based on those two studies, and some other research as well, that Jeremy Lewis has suggested we use the term rotator cuff related shoulder pain as opposed to subacromial impingement or even subacromial pain syndrome. Syndrome implies negative things as far as I'm aware. So rotator cuff related shoulder pain is the diagnosis that I go for. Some people use subacromial pain syndrome. Some people like to use pathoanatomical diagnoses, but I tend to prefer rotator cuff related shoulder pain.
Yeah, no, that's thank you for taking us through that little bit of background there around why this term, and it's probably more from a clinical point of view where practitioners need to be mindful of this language now, but certainly I've observed in my professional working lifetime that the terms are still often referred to from the general population of, tendonitis or impingement. I think that'll be a hard thing to change for many years, but the key thing is if the people that are, advising on the right management, language communication is such a key part of good care, that this stuff really matters. So, and just on that, would you agree that impinging of structures can still certainly exist in cases where someone's got a bit of a pokey acromion process, so to speak, or something that they've in their activity status is just causing problems. A swimmer with a acromion that's a bit spurred. Would you agree that would still technically be a form of impingement? Would you still put that as a categorization of sort of more rotator cuff shoulder pain still?
Yeah, no. So I would still put it in the rotator cuff related shoulder pain, but no, I'm certainly not saying that the shoulder doesn't impinge. It does, even in healthy people as well. I'm just not convinced that it causes pathology in people to the sort of same rate that we thought it did. So in some people it may. I just don't think it's overwhelmingly the etiology behind the development of shoulder pain.
Yeah, no, noted. And I mean, the shoulder moves, it's meant to impinge, isn't it? It goes up into that arc of movement. And I often liken it to a bit like the knee, maltracking of the knee. Well, how does a knee maltrack? It's still going up and down. Exactly. So these old terms. Brilliant. Jared, so let's jump back over to management of this rotator cuff shoulder-related pain. So someone's been well diagnosed with or without imaging, and what's the next step for them? What are their goals in trying to improve their function and get back to the things they love to do?
So management is a really great area to talk about because it's actually it essentially says that physiotherapy or strength and conditioning exercises are the best way to manage somebody with anything from a rotator cuff tendinopathy to subacromial bursitis to a partial thickness tear and even an atraumatic full thickness tear. So all these pathologies or diagnoses which I've just suggested have a very good evidence base behind them for being managed with a 3-month progressive strengthening regime. Okay, so the 3-month marker there is really, really important. It's why I sort of emphasize that you have to give it time. And we've got to set expectations up from the get-go that it's not going to be a 2-week fix. You're going to have to really change the capacity or the ability of that rotator cuff to absorb force. And that can't be done with a couple of weeks of stretchy band exercises. We really need to put progressive load through that shoulder using dumbbells or some sort of machine at the gym where you can incrementally and gradually load that shoulder more and more and more to improve its capacity. So exercise-wise, it's got as good a evidence for it as surgery does, as for subacromial impingement or rotator cuff-related shoulder pain. And there was a really good study by a fellow called Catola in 2013. They did a 5-year follow-up comparing exercise therapy to subacromial decompression surgery. And again, both of those groups got better at the exact same rate after 5 years. So that was quite a dramatic study, I think. So we can say with confidence to people with shoulder pain, if you actually participate in exercise therapy for a good amount of time, for at least 3 months, then statistically your shoulder will get better at the exact same rate as surgery. Now, Brad, the thing we need to actually do there before we get too far ahead of ourselves is we need to have the patient or the person in pain on the same page as us. So we need to set expectations in alignment with ours from the get-go. So being mindful and being sort of clear in your instruction that it will take time is absolutely paramount. If we say it's going to get better in 4 weeks and it doesn't, then we lose that therapeutic alliance and rapport and we're back to square one. So I think that's the first thing that I tell somebody with shoulder pain who wants to go down the path of conservative management. Be patient. It's going to take some time.
What are the key mistakes that practitioners make, and then what are the key mistakes that individuals trying to rehabilitate this condition make?
Getting an exercise, and an exercise is a crucial part, and pretty much it's the vital part of any rehab regime. So it's getting an exercise that the person in front of you wants to do, knows how to do, and has the ability or know-how to do it. So really any exercise or any progressive loading exercise, be it a front raise, a lateral raise, an external rotation exercise, a pulling exercise, a pushing exercise, whatever, has merit. And there really is no evidence to suggest that one exercise is superior to another. So I would suggest that the mistake that most clinicians make, and myself included historically, is overcomplicating it and trying to pick or also giving a recipe-based approach regime to everyone that comes through the door with shoulder pain. Also, maybe worrying too much about what the scapula is or isn't doing, or what the thoracic spine is or isn't doing, or what the length of the pec minor or the posterior cuff is doing as well. All of those things may play a role, but I think we're getting caught up in semantics if we're focusing on that. So really, if I'm going to recommend one thing that you do, you reassure a patient, or I'm going to recommend a few things. You reassure a patient, you give them a prognosis. So you say this is going to take X amount of time, which can change and be or sort of can be dynamic over time. And then you give them one, and it can be one progressive strengthening exercise that they can do with mild or minimal discomfort. That doesn't have to be pain-free, and the literature is clear on that. It can be slightly painful. It just shouldn't stir them up over a long period of time. I like to say about a 3 out of 10 is the cutoff in terms of pain intensity there. And if you do that one exercise and you progress it, so you start with 1 kilo, you go to 2, 3, so on and so forth, and you increase the range of motion that you're doing it on, or you increase the repetitions, some part of it must be progressive, so you're putting a little bit more load through the shoulder every single time, then that would be the 2 or 3 things that I would really recommend every clinician do. If you do those 3 things well, 95% of your people with shoulder pain will get better.
So reassure the patient, the individual, give a realistic prognosis, and 3, make sure there's a progressive exercise in place. And you mentioned, 1, is it okay to give more?
It certainly is okay to give more, certainly, but at a minimum, 1 is sufficient.
I think that prognosis is so key. I think every therapist can relate to times when they haven't been well informed on that, and ultimately the individual is disappointed when they're not meeting certain thresholds as they go.
Sure.
What tools do you like to use to help point the way in terms of improvements in maybe strength or function? Are there any sort of go-tos that, Jared, that you like to use in practice for monitoring people's progress?
Yeah, so I rarely talk about pain. So exactly as you said, it's strength and function. So look, you can lift more weight. You can lift 3 kilograms heavier than what you could 3 weeks ago. Isn't that great? So you focus on what they can do. You also focus on the function. So like you said, is it getting a little bit easier around the house to hang the washing up, to groom yourself, to get dressed in the morning, whatever is important to that person? Are you sleeping a bit better at night time now? Is your shoulder less disabling in your day-to-day activity? So they're the things that I really focus on. I barely even ask people for their pain out of 10 anymore, because I find by really honing in on the pain, we're perpetuating that issue. So if we focus on function and what they can do, so their ability to be resilient and function with a small amount of pain is really so important. And there's an outcome measure for the clinicians out there that I like to use a lot, and that's the DASH, so the disability of the shoulder and hand. That's the that's the outcome measure that I typically run through there.
Brilliant. Focus on the strength and the function, and don't get bogged down in conversations around pain. Brilliant. Before we jump over to discuss, I guess, topic 2, the frozen shoulder, Jared, injection therapies for rotator cuff conditions and related shoulder pain. What can you share around injections? A lot of the time people might walk in and say, well, my neighbour had the injection, they're doing better. Should I go get the injection physio or doctor?
Yeah, so look, it's such an interesting topic, because no matter who you speak to, they might have a different opinion on it, and that's sort of health practitioner and patient alike. So look, I'll speak about the evidence, because I think that's the most objective way to look at this, and it's the evidence isn't great for cortisone or corticosteroid injections for subacromial pain issues. There is a famous systematic review, meta-analysis and systematic review that came out a couple of years ago, which suggested very, very clearly that it took 1 in 5 injections or corticosteroid injections for people to get better, more than a placebo. So you needed to give out 5 injections to 5 different people, and only one of those people would have a better result than a placebo injection, and that effect was lost at 3 months. So there's only a 20% chance that you're going to have a good result better than a placebo injection, and that effect is lost entirely up to 3 months. Having said all of that, Brad, I've had experience, and you've had experience with people who've probably had a corticosteroid injection, and it's miraculously fixed their shoulder pain. So I'm not against them. I'm just very much for trialing a concerted period of conservative management first. And if that isn't working to their desired level, then we can consider a corticosteroid injection. And the only other thing I'll add about a corticosteroid injection is that it's not without harm, okay? It has a catabolic effect on the tendons. It can actually retard the healing process and cause necrosis within the tendon. So in a young person, someone less than 40 years of age, for example, I would really think twice about recommending getting an injection to that into that shoulder, given what it may do down the line. Are you just setting that person up for a full thickness tear quicker than they have to? If it's in an elder or a more mature person who doesn't need another 50 years out of their shoulder and they just want to get to sleep at night and have no pain, by all means go for an injection. So I think there's 2 camps that we need to consider.
You're listening to Jared Powell, the shoulder physio, on all things shoulder pain and rehabilitation on this expert edition. Support for today's show comes from the Gold Coast Marathon. Just like the Physical Performance Show, the Gold Coast Marathon encourages runners of all ages and abilities to push their boundaries and strive to complete a personal challenge. The Gold Coast Marathon is held annually on the first weekend in July and is a must-do event for any budding athlete, weekend warrior, or family looking for a challenge to complete together. Run for the good times at the Gold Coast Marathon. Visit goldcoastmarathon.com.au. Support for today's show also comes from Pogo Physio. We exist to help you get back to your physical best following injury. We want everyone who walks through the doors of Pogo Physio to complete their rehabilitation, get back to their physical best, and cross their physio finish line. In order to get there, we do not want to see you for a session more than what you need or a session less. We just want to ensure that you cross that physio finish line. In addition to traditional session-to-session pay-as-you-go appointments, we offer some industry-first, unique and award-winning treatment options, including our very popular monthly Wellness Booster packs. To find out more, jump over to pogophysio.com.au. For now, let's jump back with shoulder physio, PhD scholar Jared Powell on this, an expert edition on all things shoulder pain and rehabilitation. Let's talk frozen shoulder. What a topic. I think it is one of the most diagnosed conditions inaccurately. I think most people listening would go, I know someone that's got a frozen shoulder or that had one, but do they actually is another thing. So frozen shoulder, you've put out recently a great literature review and you start it like this: frozen shoulder, full stop, the enigma, full stop, often referred to as the last remaining mystery in musculoskeletal medicine. I, as in Jared Powell, thinks this is overly dramatic. We actually know quite a lot about frozen shoulder and are slowly unravelling some of the uncertainty surrounding diagnosis and management. So, Jared, unravel away.
All right. So firstly, diagnosis, absolutely vital. So it's a very easy diagnosis. It's actually the easiest diagnosis of the shoulder, in my opinion. It's an equal restriction between active movement, so how far you can move your own arm, versus passive movement and how far somebody else can move your arm. If those two ranges of motion are equal or not dramatically different within a few degrees of each other, then that is how you diagnose frozen shoulder in the presence, and this is an absolute must, in the presence of a normal X-ray. And so we need to get an X-ray on anybody we suspect with a frozen shoulder to rule out any sinister pathology that may be masquerading as a frozen shoulder. So diagnosis is key. And so just quickly, so things that can masquerade as a frozen shoulder. And look, I don't want to obsess about this because it only happens to a very small proportion of people, but we need to be aware of a neoplasm or some sort of malignancy or cancer within the shoulder complex. That will present very, very similarly to a frozen shoulder. And in a few percentage of people who are diagnosed with a frozen shoulder, they will actually have some sort of malignancy in their shoulder. So an X-ray will reveal that very, very quickly and may in fact save their life. So I would never, ever forget to get an X-ray on somebody who I suspect has a frozen shoulder. So that's number one. Number two is looking at glenohumeral joint osteoarthritis. So this can present quite similarly to frozen shoulder with some major differences. So an X-ray will reveal very clearly whether there's any glenohumeral joint osteoarthritis. So the arthritis guys will present, it's a bit more of an insidious onset. The pain isn't as severe. They'll probably have a little bit more movement, and it's not going to be that classic restriction of your external rotation and internal rotation where it's profoundly lost. So a glenohumeral joint arthritis presentation will be stiff, but not as stiff as a frozen shoulder. And then another thing you need to rule out with an X-ray as well is a locked dislocation. So don't underestimate this. So somebody can have a dislocation and they think that the pain gets better or it's relocated, and that dislocation can remain partially subluxed or out indefinitely. So an X-ray will reveal that as well. So those are the three things that I truly sort of encourage people to get an X-ray for if a diagnosis of frozen shoulder is suspected.
So just to recap, ruling out the potential partial dislocation, glenohumeral osteoarthritis, or osteoarthritis of the shoulder joint, if you like, simply, and potential for anything more sinister, such as a neoplasm or bony metastases of the shoulder. So, and just to go back, Jared, equal restriction of active, or the ability for someone to lift their arm up or out to the side, and then for someone to do that to that arm. This correct me if I'm wrong, but presents globally for the shoulder. So people will come in and they have trouble going to the front, to the side, reaching behind, rotating out, correct?
Correct, exactly right. So that's exactly right. Frozen shoulder people may have a bit more restriction in external and internal rotation. Don't forget, it's not just an issue with external rotation. So internal rotation is sometimes even more profoundly affected of people with frozen shoulder. So don't just look for the external rotation, which I know I was taught at university, but it can affect and abduction as well. Like, people will struggle to get their arm above 60 degrees of abduction in a true frozen shoulder.
What can people that have been accurately diagnosed with a frozen shoulder, expect? You talked about the need to give a realistic prognosis as part of good management. So what can they expect?
So dispelling another myth, there's really been no evidence that frozen shoulder resolves by itself organically without intervention after 2 years or 2.5 years. There was a great systematic review that came out by Wong, I think in 2018, which suggested that this is a mere myth. So it's unethical, in my opinion, to diagnose somebody with frozen shoulder and say it's going to get better by itself within a couple of years, because we know categorically that some people 4, 5, 6, 7 years later, and even up to half of those people, remain symptomatic in some form. So whether they still have pain or stiffness or some sort of functional deficit. So most people with a frozen shoulder continue to have pain well beyond the 2.5 years. So this, it's just a myth. It just doesn't get better by itself in 2.5 years. So what can somebody expect? So we know that there are some interventions out there that might be able to reduce the time course of their problem or their pain symptoms, and they're mainly related to an intra-articular, so injections inside the shoulder joint itself, which is very different to a subacromial injection. And so those injections are called either a hydrodilatation, which is a high volume injection, typically 40 mil, and then there's a low volume injection of usually just cortisone, and that goes directly into the shoulder joint itself. And then you can even get subacromial injections in addition to these intra-articular injections as well. And so all three of these injections have some form of evidence for them. Basically, they are better than doing nothing. That's what the evidence suggests. How I tend to approach it is that we get a hydrodilatation or even a low volume injection. If they're really on, if you got them within the first 2 or 3 months, and we don't think that there's a capsular contracture just yet, and we'll get back to that in a minute. So if we think that the capsule still hasn't contracted, but they've just got this inflammatory synovitis going on inside the joint, then even a low volume steroid injection might be of benefit to that person. But either way, I tend to recommend getting an injection to start with, and then it's pretty consistent physiotherapy. And the physiotherapy involves not just passive therapy, but it's getting that arm moving. So it's getting them to start some classic rotator cuff strengthening exercise, or just general loading exercise, or active assisted or active range of motion exercises as well. Trying to get that arm moving and not let muscle atrophy and kinesiophobia, more importantly, take over. Because once you stop moving your arm for 6 months, it's really, really hard to get it moving again, not just physically, but also psychologically. And so that's the pathway I tend to go down there. I tend to recommend getting an injection in whatever form it may be, whether it's a low volume or a high volume, and then it's a course of physiotherapy. But I'm honest, it's like this could take 12 months, but it's probably going to be better going down this pathway and it taking 12 months and having pain for the next 5 years if you don't do much about it.
And is there a time frame where there's a difference for people to get injections done? Is there any merit to them sort of missing the boat and it's no longer going to help them?
Yeah, so no time frame, but how I call it is pain greater than stiffness. So if your pain is more severe than your stiffness, then a low volume injection may be of benefit. If your stiffness is greater than your pain, so the pain isn't great but you just can't move your arm, then a high volume injection to maybe try and dilate the capsule, which is the whole purpose of the hydrodilatation injection, then you may go for that one there. So pain greater than stiffness, low volume, stiffness performance greater than pain, high volume.
And to actually practically get these injections done, Jared, are people getting a referral from a GP to a radiology clinic or seeing an orthopaedic surgeon to do it in their rooms?
Yeah, precisely. So I'm lucky to work with some GPs, and I refer them straight back to the GP, and the GP is very happy to refer them on for a hydrodilatation injection. And look, I work very closely with lots of shoulder surgeons as well, and they also refer for a hydrodilatation injection, followed closely by heavy physiotherapy for it as well. So no surgeons really want to operate on a frozen shoulder until they've exhausted injection therapy and physiotherapy. That's because we know the results of a capsular release or a manipulation under anaesthetic aren't that great. And all the surgeons that I work with here on the Gold Coast at John Flynn and at Pindara highly recommend that approach as well.
Yeah, and certainly I've noticed in my time in the profession that, manipulation under anaesthetics fortunately do seem to be a thing of the past. So that's what people can expect, and I think you've killed a great sacred cow there, that it just won't necessarily be better off left alone to run its own course. In terms of populations where this is more prevalent and any known causes, can you speak to those two things? Who might we expect to see a frozen shoulder in, and do we have any idea of why these things are developing?
So demographic is very, very clearly in the age groups of 40 to 60, or at a push 65. I've seen one person under 40 have it in all my time, and I've probably only seen one or two over 60. In Japan, it's called the 50-year-old shoulder. Okay, so that speaks a lot to how prevalent that condition is around the half-century mark. In terms of population, is there a gender bias? Yes, it's slightly more common in women than men, but it isn't dramatic. So it's not like 70% to 30%. It might be 55% to 45%. I certainly see my fair share of men who get a frozen shoulder as well. So that dispels that myth. It's not just a condition that affects females. It also affects males almost as much. And in terms of people who are predisposed to it, it seems to be more prevalent in a diabetic population. Up to 30% of diabetics will go on to develop a frozen shoulder. I don't know why. It's got something to do with the clearance of glucose from their connective tissue. It's complex. We don't have an answer to that. So some people actually with long-term type 1 diabetes, so people who've had diabetes for longer than 40 years, they've got a 70% prevalence of developing a frozen shoulder in their lifetime. So that's a phenomenal statistic as far as I'm concerned. And then it's also associated with thyroid pathology, particularly hypothyroidism. It's very firmly correlated with that. And then also a Dupuytren's contracture, which is a contracture of some of your fingers in your hand as well. And it's a very similar presentation to that, where you get this contracture of the connective tissue. And in terms of why it all happens, like we still don't know. The 70% of all frozen shoulders we think are idiopathic, meaning without cause. So that's still the bulk of people who get a frozen shoulder. So that's a primary idiopathic frozen shoulder. The other way we look at the ones who aren't primary are secondary frozen shoulder. And then we can further subcategorize that into intrinsic, extrinsic, and systemic. So intrinsic is if you've had long-term rotator cuff pain. That can eventually maybe lead to a frozen shoulder. And extrinsic is if you've had neck pain, for example, a cervical radiculopathy, or you've broken a collarbone or something like that. That can lead to a secondary extrinsic frozen shoulder. And then this systemic bunch, which I talked about before, that includes your diabetic and your hypothyroid populations as well. And I think, sorry, Brad, I think it also includes maybe people with long-term hypertension, or what we call more broadly metabolic syndrome, when there's issues with hypertension, hypercholesterolemia, and there's issues with clearance of glucose, which is your diabetes as well.
You're listening to Jared Powell on this, an expert edition of the Physical Performance Show, focusing on all things shoulder pain and rehabilitation. If you missed last week's episode featuring South African trail running champion Ryan Sands, then here's a little snippet of what you missed.
Yeah, so I'm currently I guess I found what works best for me is to kind of be as consistent as possible with training, but then I'm not someone that does huge like volume of training. Currently, like this week, I'm going to be doing 100 miles or like 160, 170 kilometers. Nothing like too short and sharp, but more just kind of long sustained efforts. Some stuff at like kind of Western States race pace, just to try and kind of get dialed into the race as much as possible.
To tune into the full episode featuring Ryan Sands, jump over to wherever it is that you enjoy your podcast from and enjoy the highs, lows and learnings. While there, be sure to check out the archives of the show dating right back to surf life-saving Ironman champion Ali Day on episode 1. For now, let's jump back with Jared Powell on this expert edition, focusing on all things shoulder pain and rehabilitation. Jared, the frozen shoulder, continuum of symptoms, if you like. People often just generally speak to freezing, frozen, thawing. Can you speak to that from your professional experience and also the evidence?
So the literature suggests it doesn't really follow that pathway beautifully. Maybe they overlap a bit, and maybe people do progress loosely through a freezing, frozen, thawing phase. I've definitely seen it where it's really sore and then it's really stiff and then the stiffness starts to abate. And I've certainly seen that, but it's not 6 months in each phase or anything like that. So, but to be honest, do I actually suggest to people with a frozen shoulder? I think it's a very nice way for them to consider how they're progressing down the spectrum or continuum of frozen shoulder. I think it's helpful. I think it provides an end point, as it were, and it gives them something to aim to. So the literature isn't firm on it following this continuum beautifully. I think maybe roughly it's there, but in somewhat more of an overlapping manner. But I think it's very helpful for people with a frozen shoulder to see how they may be progressing on a spectrum.
All right, so Jared, injections, and just to quickly throw back, would you suggest, or is there any literature around repeat injections? As you said, there's high volume and low volume depending on their pain and stiffnesses, but is that something that you've clinically observed?
Yeah, definitely. So I work pretty closely with a surgeon locally here on the coast, and he recommends a hydrodilatation 3 times every 6 weeks. And I've seen lots of patients with that, and I've seen some amazing results with that, and conversely, I've seen some not so good results with that. I've also seen dramatic results with a person with 1 injection. And so I think a lot of it comes down to the individual presentation in front of you. So certainly repeat injections are routinely performed. Do I see them as being superior to 1 or 2? I probably don't at this stage, but I guess watch this space.
Yeah, wow. So I am taking notes upon notes here, Jared. And in terms of treatment beyond injection therapy, you mentioned the need to get a frozen shoulder individual, loading it up and confident to move and not fearful of moving it. Anything else you'd add to the treatment and management of frozen shoulder? Yeah,
so I do a lot of manual therapy in people with frozen shoulder. I think it's very helpful in modulating or desensitizing their symptoms. I don't think I'm really breaking anything up or doing anything like that. I think I'm just maybe taking away some sensitivity and pain around the shoulder. I do a lot of glenohumeral joint mobilizations in them as well. I think that they're quite effective too. But I spend a hell of a lot of time on education and advice and encouraging them to move their shoulder in a way that is suitable and appropriate to them. So a combination between active and passive strategies I tend to employ in a frozen shoulder population, because we know, look, frozen shoulder essentially becomes a chronic pain condition or a persistent pain condition, if you want to look at it like that. So we need to be very careful about psychological symptoms developing, such as anxiety, catastrophizing, fear of movement, and all of these things. And so we know if you develop these symptoms that they can perpetuate the time course of your pathology, even once the physical issue is actually healed. So that's where the education and the exercise becomes really important.
Jared, if you had to boil, this is a very difficult question for you, but in your career to date, which is obviously both clinically based and also research based, everything you've learnt to one piece of advice for someone out there listening in who has a sore shoulder, unknown diagnosed, it's not diagnosed yet, but just has a sore shoulder that's not getting better, it's starting to limit their ability to do things in life. what would be your one bit of advice to that individual?
Exercise it. Just categorically exercise it. You've got to move it, okay? And I don't view exercise as just a physical intervention. Look, I'm not trying to hypertrophy the rotator cuff. It just doesn't work like that. Fantastic if it does, but I'm trying to develop a resilience, which is a buzzword, or a capacity of the shoulder to tolerate the load that they want to put through their shoulder. So if they're 70 years old and they want to play bowls, they need to have a certain amount of capacity in their shoulder. And you can't rest it better, you can't inject it better, and I don't think you can rub it better either. You have to apply some form of external load to that shoulder. But that will also have psychological implications as well. It will improve feelings of confidence in the shoulder. It will improve feelings or provide feelings of resilience in that shoulder. And they will start to experiment with movement. And we know that people who start to move their arm a lot more will typically not be afraid of moving their arm anymore, because we know the brain can actually learn to provide a painful output even once the actual tissue is healed, because they're scared or the brain associates that movement with pain. So you've got to rewrite those pain memories sometimes. And I use exercise to rewrite those pain memories, what we call graded exposure to movement. And so really exercise your shoulder if it's sore, and it works on not just physical but also psychological factors as well.
And I can't, tell you, and you would have experienced this too, Jared, how many people report to us as practitioners that, oh, gosh, I've rested this shoulder, it feels worse, but when I use it, it feels better. Brilliant. Jared, in terms of where we can find you, work with you, I professionally will be joining you to be sitting under your teachings in a few weeks' time from the time of recording at your shoulder management course, which you conduct around Australia. That's great for practitioners. Where can the general public follow you, find you, etc.?
So, mate, I'm all over Instagram, Brad, as you know. I'm addicted to Instagram. So I'm on shoulder_physio. So my aim on Instagram is to essentially post recent or relevant literature and put them up there in a bit of a digestible manner. And that seems to be going well. And then also my website, which is www.jaredphysio.com. And I've got a bit of a blog up there, which I run, and I release this monthly literature review, as you alluded to before, where, again, I pick out a piece of really relevant or somewhat controversial evidence, and I write about it and send it out to a bunch of people too, so they can sign up for that on my website. But so that's where you can find me.
Brilliant. And then clinically, you're in practice, Tweed Heads, New South Wales?
Tweed Heads, yeah, exactly right, at a clinic called Physio Place, and also at the Tweed Health for Everyone GP Super Clinic, where I work a couple of days a week as well.
Brilliant. And obviously research is being conducted, correct me if I'm wrong, out of Bond University?
Bond University, yep. And I'm also a facilitator, and I teach the shoulder there as well. So, yeah, plenty of places to find me.
Jared Powell, thank you for sharing your love, passion and knowledge around all things shoulder pain today.
No worries, Brad. Thank you for having me.
So there you have it, another episode of the Physical Performance Show, and I trust that you took a lot from Jared Powell's sharings today. If you did, be sure to let Jared know. He's easily found over on Instagram at shoulder_physio. Do let Jared know what it was that you took from the show, and be sure to share this episode with anyone in your world that is experiencing shoulder pain. Jared's on a crusade to improve the quality of shoulder rehabilitation, and by sharing the show, not only will be helping that significant other or friend, you'll also be helping Jared on his quest of improving the overall standard of rehabilitation for shoulders worldwide. Jared has some great resources as well over on his website. We'll tag everything up on the show notes over at Pogo Physio, or simply jump over to jaredphysio.com. That's JARED physio.com. If you're a practitioner, Jared has a great mailing list which you can subscribe to get a monthly update. Massive thanks to the three good folk who make this show possible each and every week. That's Daryl Misson, audio engineer, Susan Wilkin on all things show administration, and Matthew Walding on all things graphic design. Of course, another huge thanks to today's show sponsor, the Gold Coast Marathon. If you are looking for a great mid-year event down under, then look no further than the Gold Coast Marathon. There is an event for everyone, ranging from the junior dash right through to the full feature-length marathon. Thank you if you have been subscribing to the show. That truly is the best way to help the show grow. And a massive thanks to those leaving reviews over on iTunes. This week, a huge thank you to Nads76, who commented, "Love listening to this podcast. Mix of entertainment and professional insights which have done wonders for my athletic objectives. Thanks to Brad and the experts with their tips, I overcame an Achilles problem to run a sub 3-hour marathon. Outstanding stuff." Nads, thank you for taking the time to leave that review. And if you're yet to leave a review, and we'll be happy to do so, you can simply do that from iTunes from your phone or a laptop computer. Now, coming up on next week's episode of the Physical Performance Show, I bring you a very fun and fascinating conversation that I have with Team Haas Formula One racing physiotherapist to French driver Romain Grosjean, Kim Keedle. Kim's got a great story as a physiotherapist graduating from Melbourne and finding himself in the world of F1 racing. Whether you're an F1 racing fan or not, Kim offers up some incredible insights into the rigors that the F1 drivers face, the behind the scenes of what goes on in keeping the drivers healthy, and so much more. So be sure to be tuning in next week to the Physical Performance Show. Until then, keep pursuing your physical best. I'm Brad Beer, and this has been the Physical Performance Show.